Good morning, everyone, and welcome to Houston Methodist DeBakey Heart and Vascular Center Grand Rounds. We have a terrific speaker this morning, but first, a few housekeeping items. We'd love to get questions for the speaker today, and you can do that through the web. If you go on polev.com/DeBakey, or you can go by text, and that's at, please text DeBakey, D-E-B-A-K-E-Y, to 37607, and please send in your questions. It's a real honor for us and a personal pleasure for me to introduce our Grand Round speaker for today, Dr. Joseph Sabik. He is the Chair of Surgery and Surgeon-in-Chief at the University Hospital's Cleveland Medical Center, and he is the Vice President of Surgical Operations there. Joe is an internationally recognized cardiac surgeon, and to many of us, the Yoda of coronary and cardiac surgery. Joe was he is a native of Massachusetts. He went to school at MIT and then to Harvard Medical School. He was a general surgery resident with me at the Mass General in Boston, before going to the Cleveland Clinic, where he trained in cardiac and thoracic surgery. They were smart at the Cleveland Clinic and hired Joe on staff there, where he quickly rose to become the chair of cardiac and thoracic surgery at Cleveland Clinic, before assuming his position now across town in Cleveland as the chair of surgery at that esteemed institution. Joe is a prolific writer in fields of cardiac surgery. He's a member of all of the big organizations and associations in organized medicine and surgery. And one of Joe's particular interests and expertise is coronary surgery, and that's the topic, advanced coronary surgery, that he will speak with us about today. So welcome, Joe. Looking forward to hearing you talk.
Thank you, Tom, and thank you very much for that very, very kind introduction. It's a real honor for me to be here today, obviously virtually, but again, it is such a privilege. As Tom said, I really enjoy coronary surgery. I suppose I may be a little historic when it comes to heart surgeons, because this is really a passion of mine and something that I have really enjoyed doing and investigating, over the last, I suppose 2 to 3 decades. And so, what I would like to do today is to talk to you a little bit about, how I approach coronary surgery, what I have learned, both in my research efforts as well as in my clinical practice. And I hope you'll, come away with today, learning a few things about maybe how we can make coronary surgery better for everyone. In terms of disclosures, I don't have any disclosures that are relevant to this presentation. I'm not going to talk about a product or any commercial entity. As I said, we're going to talk about coronary surgery, and maybe I thought I might outline some of the kind of big points that I hope you all take away today. As you know, we have many choices in coronary artery bypass grafting conduits, and we're going to talk about what I think are the best ones. Obviously, this is going to focus around arterial grafting, because I think there's a lot of data out there to suggest that that's really where coronary surgery has to go. And then I'm going to also talk a little bit about, for the surgeons in the audience, kind of the technical tricks and some of the pearls to doing all arterial revascularization, again, and how I feel about it and how I do it. I think it's always nice to start with a case. This can help, bring home, some of the concepts. And I'm going to talk about a patient that I have taken care of. He's a young man, just 40 years old, who had presented with chest pain. He had a very high lipid panel. He was overweight, and he was a smoker. Obviously some pretty important risk factors. And on top of that, he had a very, very strong family history for early coronary artery disease. During his workup, he had an echocardiogram, which showed normal function and normal valves, and a stress test, which was very positive. And then he underwent this angiogram. And here you can see on this injection of his left coronary artery, that he has pretty severe and extensive coronary artery disease, involving his left anterior descending, his diagonal branches, as well as the circumflex branches. Here's another view of the left coronary system again, which I think clearly demonstrates the extensiveness of his coronary artery disease, and one chart of the right coronary artery, which again shows some moderate disease, I think, in the main right coronary artery, but some severe disease in his posterior descending artery. Now, I don't think this is going to come to us as a surprise to anyone, but when we look at the most important predictor of whether or not a coronary artery bypass operation is going to be effective, is really dependent on whether the grafts stay open. And so when we choose to do a coronary operation, what we really want to do is to choose the best grafts, because that's going to give our patients the best chance at a very long and excellent survival that is free of recurrent ischemic events and the necessity for repeat reintervention. I mean, I think this was really well known back in the early 80s. And I really had a wonderful conversation with Fred Loop, and I was a resident at the time, and I was just trying to pick his brain a little bit. And I said, Dr. Loop, how did you know that the internal thoracic artery, or we call it in Cleveland the internal thoracic artery, I know the rest of the world calls it the internal mammary artery, was going to stay open and was going to be effective? And he said, oh, that was easy, Joe. He said, when I first started in my practice, there were a lot of these patients who had Weinbergs. And as those of you who might not know what a Weinberg was, is before we knew really how to do a direct anastomosis of a bypass graft to a coronary artery, they took the mammary artery and actually tunneled it in the anterior wall. And you wouldn't think this would do anything, but the internal mammary stayed open, and not in all, but in many, patients developed these small collaterals to the major coronary arteries. And I have to admit, early in my practice, I saw patients who had a patent Weinberg, and all their native coronaries were occluded, and they were living off this mammary the size of a femoral artery. And he said, we had all these patients that had that, and at the same time, we were doing these vein grafts, and we were seeing patients come back a few years later with the development of vein graft atherosclerosis and then occlusion. And he said it was just that observational knowledge that convinced him that internal mammary arteries were the way to go, and again, obviously led to that seminal paper in 1986. So again, I think it's been just known for a very long time that when we choose better grafts, our patients are going to do better and benefit from that. And so I said earlier, it's kind of been a passion of mine really to kind of understand coronary surgery and what we can do to make it better. And again, another little, story. When I started my practice at the clinic, Fred Loop, back, I think it was 1971, had started what he called the CVIR, which was the first cardiovascular information registry. And he had the foresight to say, if we're going to really understand, what we do to patients, we really need to follow them. And so started this registry in the early 70s of all patients that had coronary artery disease. And they followed patients who had coronary artery bypass surgery. And they also entered into this registry all the cath data that these patients had during their lives. And I'll be honest with you, when I came on surgery as a heart surgeon, I wasn't that excited about being a coronary surgeon. I thought, geez, everything had been done, everything had been known. I wanted to do something else. And Dr. Cosgrove came into my office and said, no, Joe, I really need you to write about coronary surgery because I have this database that had over 50,000 patients in it with about 250,000, patient years of data, and nobody is writing about it, and I want you to write about it. And it turned out to be one of the best things that ever happened to me in terms of my academic career and then, affecting my clinical career, because there was all this data for me to work with. And I thought, well, I kind of am interested in this patency thing. And so we really kind of did just a dive to try to understand the factors that influence whether or not a graft is going to stay open, looking at patient factors, looking at factors from cath labs, looking at habits. And so it was really a fun time for me. This is kind of summarizing, I think, kind of briefly, and then we're going to get into a little bit more depth of understanding this, But what really are the factors that influence graft patency? The first one was time. You know, the greater you get away from an operation, the less likely the graft was to stay open. But as we're going to talk about, this was just true for vein grafts. It didn't really apply to arterial grafts, and we can talk a little bit about that as to why. That there were certain factors about the coronary artery that determined whether or not a graft would stay open. There are certain coronary arteries that just seem to intrinsically, grafts had better patency when constructed to them. And that probably has to do with things like outflow and the amount of myocardium served. But a very important thing was what I would call competitive flow. And competitive flow is the residual flow in a coronary artery after the obstruction. And so as one can imagine, if an artery is obstructed 50%, there is a lot more residual or competitive flow in that artery as opposed to if that artery is 90% obstructed. Now, for many of you in the audience, particularly the cardiologists, would say, well, you know, we got FFR and stuff, but I have to admit, you know, we did a lot of this before FFR. And FFR still isn't something that we really have access to as surgeons, because we recently did a study in the STS database where less than 1 in 20 patients undergoing coronary surgery are actually having their arteries examined by FFR. And so for us as surgeons, we're still, you know, very, very visual in determining whether or not we should graft an artery. Now, obviously this may change, particularly with technology such as heart flow. But right now, I know there's a lot of discussion about FFR and how that should influence it, but it really hasn't become practical. The third thing I think we can talk about is the actual conduit. You know, as I said, that there are certain conduits that are going to have better patency than others, as demonstrated in that story from Dr. Loop about the Weinberg operation. And we know that vein grafts tend not to last as long as arterial grafts, and we're going to talk a little bit about that. And then there are certain patient factors. Younger patients, grafts don't appear to last as long, and in women. And this may have to do with the extensiveness of the disease that we see in young patients, and also in women, the size of their coronary arteries. But let's talk a little bit about these different things. And, you know, the first thing, as I said, we can talk about time. And this looks at graft patency by time, and along the horizontal axis is years from CABG. And then along the vertical axis is the percentage of grafts patent. The darker blue is IMA or ITA grafts, and the lighter blue is vein grafts. And one of the things you can see about ITA grafts is that their patency tends to last a very long time. So if that graft is open when you finish an operation, it's very likely to stay open for a very long time. And the reason for that is that internal thoracic arteries seem to be immune from the development of atherosclerosis. And so if the graft is open, it stays open. A very, very different story with vein grafts. As you can see, vein grafts decline over time. And I think there's an important reason for that, and that really has to do with veins develop atherosclerosis. Now, why? You know, when we take a vein and we harvest it, we can injure the intima. And then also when we put that vein in an arterial circulation, now all of a sudden that vein is exposed to arterial pressures and not venous pressures. And again, we can result in more intimal injury. You know, this intimal injury leads to platelet adherence. The platelets excrete mitogenic factors, which leads to development of intimal hyperplasia in the vein graft. And that is the precursor, to vein graft atherosclerosis. And so what we see when we implant a vein graft is that we have kind of a higher early occlusion rate, and then a steady decline over time. And this decline is due to the development of vein graft atherosclerosis, so that by 10 years, only half of our vein grafts are patent. And of those that are patent, at least 50% of them have demonstrated or are demonstrating vein graft atherosclerosis. Now, there are treatments that we can do today which would improve vein graft patency. You know, we know that the use of aspirin and antiplatelets are important for vein grafts. And that probably has to do with the prevention of early platelet adherence. And we know that you need to get those platelets, those antiplatelet agents to the patients within 6 hours of surgery. And then obviously cholesterol-lowering medicines have also been extremely important because it can slow or halt the development of atherosclerosis. The other thing that I mentioned was it's dependent on the artery. And again, in that light blue line is when you construct a mammary graft to the LAD, where we see our best patency. And then in the yellow line, when the graft is constructed to the RCA, it has the worst patency. And then the intermediate arteries are those such as the diagonal, the circumflex, and the posterior descending artery. Now, probably the most important thing in influencing whether or not an arterial graft will stay open would be competitive flow. And the way I like to explain it to my residents and medical students are that, arterial grafts are smart. If you put an arterial graft to an artery that is just moderately obstructed and has a lot of competitive flow, it's very possible that your arterial graft is not needed. And so its physiologic response would be to constrict and maybe atrophy over time. And that can lead to failure. But the important thing I think here to consider is that at least when I began my career, I was told, geez, you never want to use an arterial graft below a 70% obstruction because you have a dramatic fall off in your arterial graft patency. And we did not find that. And looking at well over 2,000, IMA grafts that were constructed to different arteries on the heart, what we saw was a gradual decline. And this was particularly true in grafting the LAD. If you graft a non-LAD, competitive flow seems to be a little bit more important and have a stronger effect on whether the graft will stay open, but not nearly as dramatic as we think. And it really, as you can see, even at a moderate stenosis of a non-LAD, you're still ending up with a 80% patency of that graft. And I think that is relatively important. And although we're not going to talk about it today, there's a big kind of controversy in the surgical world as what to do with moderately stenosed arteries. I would argue it depends on what graft you're going to use. And that really is the importance, but that can be a topic maybe for questions or another day. What happens when we put competitive flow and time together? Well, as we said, the arterial grafts do not develop atherosclerosis, and so they tend to be relatively patent over decades of surgery. So very different than vein grafts, and again, I think an important consideration. So I think you can all say, well, this is nice, but how does this help me? And so we really wanted to bring all of this data together and say, okay, let's bring in these effects of competitive flow and arteries bypassed, and what happens when veins develop atherosclerosis over time. Because if we could put all this together, this will help us predict that if we have a 70% LAD lesion, what graft should we use to give this patient the best long-term result? And the same if we have a 50% right coronary artery lesion, what should we do? And so we kind of expanded on that knowledge that we learned, and we did some studies in different scenarios. And what we did, and the next set of graphs are all going to be similar, so I'm going to just spend a minute to explain them. Along the horizontal axis, we're going to have proximal stenosis. And so that's a surrogate for competitive flow. And along the vertical axis, we're going to have the percentage of our grafts that stay open. And we're going to look at both internal mammary or internal thoracic artery grafts, as well as vein grafts. Now, I think the first thing that you observe is that you see that the ITA graft patency declines with decreasing levels of proximal stenosis or greater competitive flow, as we talked about earlier. However, saphenous vein graft patency is flat. And the reason for that is saphenous vein grafts are dumb. They don't respond to physiology. They just stay open. And again, we were surprised at this, but we looked at over 10,000 vein grafts, and this is what we found. The patency of a vein graft is not dependent on competitive flow. And the group down in Australia looking at, again, many thousand vein grafts found the same thing. And again, this was kind of contrary to what most people thought. And then we looked at this at different time periods, and I'm going to show you at 1 and 10 years for different arteries grafted. And as you can see here, that at all levels of competitive flow or proximal stenosis, at 1 year, if you put an ITA graft to an LAD, the patency is always better than that of a saphenous vein graft. And so I think that's why there are studies that, whether they come out of the STS database or come out from my former institution, the Cleveland Clinic, that even at 1 year, using an ITA graft to the LAD results in better survival. And I think we see that very well depicted here. If we go out to 10 years and look at saphenous veins and ITA grafts, we see a larger difference in patency. And if you go back to that 1986 study done by Dr. Loop, he showed that the survival benefit increased with time. And the reason for that is the ITA grafts are stable over time. The patency doesn't decrease, as we showed, but vein grafts develop atherosclerosis, and so they decrease over time. They have their best patency to the LAD, but even in these situations, an ITA is always better. And so again, I tell my residents and medical students that ITA is like a fine wine. It just gets better with time, and its benefit becomes stronger and stronger. And when you follow these patients even out to 2 decades, as you can imagine, the benefit is even greater. Again, and this is where our patients get the survival advantage from an ITA to the LAD. Now, how about if we look at those intermediate arteries? Those arteries that, kind of don't have as good patency of arterial grafts or vein grafts to them, but still better than when we do it to the right coronary artery. And you can see at 1 year, we have benefit. And this is why 2 arterial grafts, when used properly, are better than just 1. And then what happens when we get out to 10 years? Again, we see this widening, this increasing improvement. And we see the same thing when we look at 2 ITA grafts, that benefit just increases with time. And a lot of that benefit occurs in the 2nd decade after coronary artery bypass surgery. Now, the story is a little bit different for the right coronary artery. And I know that a lot of people, have thought that, you probably should have put the ITA to the right coronary. And I think this demonstrates why. And I'll argue that this is probably due to the fact that we use proximal stenosis as a surrogate for competitive flow. And at least when these studies were done, we didn't have the ability to actually measure competitive flow. If you think of a 2 millimeter LAD, and it has a 50% stenosis, you end up with just a 1 millimeter lumen. But if you're taking a 5 or 6 millimeter right coronary artery, and it has a 50% stenosis, we're still left with a 3 millimeter lumen. And so the competitive flow or the residual flow through that stenosis is a lot greater than we see in an LAD. And that's probably why our ITAs are more susceptible to competitive flow in a right coronary. It's just the way we measure it. And so I think you have to think about matching your conduit to the size of your artery. If you have a very large ITA, it's probably going to work very well. But if it's a lady with a 1 or 1.5 millimeter ITA and you're putting that to a 5 millimeter right coronary, it's probably not going to work very well. And we see that, in this situation. And I think this is why there are studies that show 2 mammaries matter and other studies that show only 1 mammary matter. It's because how you use your mammaries is incredibly important as to whether you're going to get a benefit of that mammary. Another thing is that over time, the mammary does appear to be better, but we very rarely in these prospective studies follow our patients out to 5 or 10 years to really see, this type of benefit. So a little bit of caution. I think when using a mammary graft to the right coronary, I much prefer to put it to the PDA or a distal branch. And we're going to talk a little bit about the different ways that we can use the different mammaries and configurations, but probably not a good idea to just put it to the right coronary artery. And I think this is when you really dive into some of these studies, explains why some studies have not shown that 2 mammaries are beneficial. It has to really do with how they use them. Well, many of you know that there are a lot other arterial grafts besides the mammary arteries. We have the radial arteries, and radial arteries have become, very positive in our journals these days. And a lot of that is due to the work of Mario Gaudino, that has demonstrated that, using a mammary and a radial is just as effective as using 2 mammaries. I think the radials, when they first came out, got a lot of bad press. And I think that has to do with how they were used, and they weren't used correctly, but we've become a lot smarter. And we'll talk about that in a minute. But we also have the gastroepiploic. We have the inferior epigastric. So there are other arteries that we can use to augment the type of operations that we do. And we used to take them open, but as you'll see in a video when we go back to our case, today we do it endoscopically. You know, we see the same type of findings with the radial artery, that grafts are best when they're constructed to the LAD and worst when they're constructed to the right, and intermediate when they're constructed to the circ. And again, the radial artery is very susceptible to competitive flow like the mammary artery, and maybe more so. It is more of a muscular artery than the mammary artery. But you can see at high-grade stenosis, we can get very good outcomes. This is just another study, you know, looking at that. You can either use it off of the aorta or you can use it as a composite graft, which we'll talk about in a minute. But again, when used properly in situations of high-grade stenosis, a radial artery has excellent patency. And there have been studies that have looked at, you know, different situations. And in this study, they looked at radial arteries that were constructed to a critically stenosed left-sided artery. And you see that its patency is similar to that used in a mammary artery. But however, if you use a radial artery, let's say to a right coronary with moderate stenosis, you don't end up with very good outcomes. As you would suspect, you're all educated now and you understand that that's not the right situation to use it in. But I think when it came out, you know, when we started looking at this 20 years ago, I think we often used it in the wrong situation. And I think the radial artery got a very bad rap because of that. But now that we have studies where it's used properly, we're seeing that we can get excellent patency and can have the same influence on outcomes as two mammaries do. And I think in some ways, the radial artery is an easier graft to use. I think surgeons know it's a little bit more similar to the vein in terms of size. The thickness of the wall makes it a little bit easier to suture. It's a very nice graft to sequence. And so I expect that we will continue to see growth in radial artery usage. And as long as it's used properly, it can have excellent results. The gastroepiploic, it's something I still use. I know it's not as popular as it used to be. It's a little bit more finicky. You don't need to extend your median sternotomy incision. You know, it can be taken by just, you know, going through the upper part of the abdomen. You do have to take your TEE probe out and, you know, make sure the stomach is empty. But here it's demonstrated harvesting as a pedicle. But I know a lot of our Asian colleagues are now skeletonizing it. It's quite impressive to see them use it. But the amazing thing about it is you can get to almost anywhere on the heart once you're familiar with how to take this. I mean, you can easily reach, you know, the mid-LAD or any distal branch of the right coronary artery if needed be in a situation where you don't have conduit. This is a really excellent study done by a good friend of mine, David Glenur. And what David said was, you know, Joe, I do understand that, you know, competitive flow, when we look at proximal stenosis, that's not the best surrogate. And so what David did was look at the patency of gastroepiploic by what the minimal lumen diameter was of that vessel, which is probably a much better way of measuring. And what they found was, as you'd expect, in situations of high-grade stenosis, the gastroepiploic did extremely well, where you had either total occlusion with 0 minimal lumen diameter or very small. But when you got to larger minimal lumen diameters, the gastroepiploic, being a small artery, was very sensitive to competitive flow. But again, used in the right situation, it is an excellent conduit. And in situations where you don't have other options, it's a very good thing to use. I'd like to switch gears just a little bit now and talk about how, as surgeons, we can use these grafts to perform complete arterial revascularization. And as surgeons, we have a lot of tools. We can use them in situ, which I think is what most people are most familiar with. And that's in the situations where we keep the proximal part of our graft attached, you know, such as in an in situ left internal thoracic artery. We can also use it as a free graft, where the graft is taken off the chest wall and either anastomosed to the aorta or another conduit. We can use our grafts in a sequential technique or in a composite technique, where we, again, are putting it off another graft. And this allows for a very efficient use of arterial grafts and can reach pretty much all aspects of the heart. This is just a nice picture of what it looks like in situ, you know, where the left internal thoracic artery is used to bypass the anterior wall, and the right internal thoracic artery is used to bypass the lateral wall. But I think you can see in this situation that is probably not the most efficient way to use the right internal thoracic artery, because a lot of the graft is just used to get to the destination that we need it to go to. We might be able to more efficiently use this graft in other ways. The other graft that we commonly use in situ is the gastroepiploic, but the gastroepiploic can also be used as a free graft if you want to, and I know a lot of our Asian colleagues are doing that with a lot of success. This is a demonstration of doing a free graft where, again, it's attached to the aorta. A lot of surgeons don't like doing this because of the difference between the thickness of the mammary wall or the arterial graft wall and the aorta. But I think once you get used to it, it's a very good anastomosis, just a few pearls. You don't want to make a large opening in your aorta. I use a very small punch in this situation, maybe just a 2 millimeter punch. But once you get used to doing it, it's a very nice way to do surgery. As I said, another way to improve the efficiency is to do sequential grafting. And this is actually a patient who, reoperation, who both mammaries had been used in the past, and for some reason they had failed. And we used a radial artery graft to revascularize the anterior wall in a very extensive sequential fashion, grafting the LAD and diagonals in this situation. As I said, sequential grafting really offers the benefit of being able to use one arterial graft to bypass multiple arteries, and very beneficial in reoperations or in patients who are radial dominant and you have limited arterial conduit. Just a little bit about the way I think about it, because I do think about sequential grafting a little different than most. I actually like to start proximally and work distally, just because I find moving that graft around makes it a lot easier. It's extremely important to get your length right, otherwise your graft will kink. So it's important to pressurize the graft when you're doing your sequentials, as well as filling or distending the heart. I think it's important to think a little bit about the layout, and I'm going to show you this in the video about how you orient your graft, particularly when you're doing kind of an in situ diagonal to LAD. If that diagonal comes off very high or is perpendicular to the LAD, you risk kinking your IMA graft and can lead to problems. And then also, I think it's important to remember that when you fix a graft in two places, it can twist upon itself in the middle, and important to tack it down in the center. And I'm going to show you that in the video. I think you do have to consider your graft as well as your coronary artery. If your graft is much smaller than the coronary artery, you're probably best doing a parallel as opposed to a diamond anastomosis. Because if you do a diamond anastomosis in that situation and you open your coronary artery, your arteriotomy is 1 to 1.5 the length of the diameter, you risk flattening that graft and sealing it, which can lead to obstruction. So again, I think it's worth spending some time looking at the size of your conduit and the coronary and determining what kind of sequential you're going to do, just to make sure that it lies very nicely and open. And I'm going to try to show you that in the video at the end. And then again, I do think you need to think about competitive flow. Some people would not want to have a vessel used in a sequential that had a moderate stenosis, because that could lead to a coronary anastomosis. And a lot of us like to believe that it's probably best to end your sequential graft with the best runoff, which can lead to better patency over time. Now, I know many of you in the audience are questioning this, saying, geez, do you really want to sacrifice your lima to LAD? We know that's so important. Do you really compromise the patency of that graft when you do a sequential graft? And so we actually studied it. Again, we had a lot of patients who had follow-up angiograms, who had sequential grafts and free grafts and in situ grafts. And I'd like to share that with you, at least the way, we thought about it. So when you have a sequential graft, you really have two components. You have the segment before the sequential graft and the part after the sequential graft. And we looked at the patency to see if doing a sequential graft actually harmed the patency of the graft. And what we found was that we had an extremely low occlusion rate of the segment before the sequential graft, and then again a very low occlusion rate beyond the sequential graft. But knowing that we really needed to have a very high bar, we compared the patencies of these to just an in situ LAD that we know is excellent. And what we found when we adjusted for all of those things that you guys heard about earlier, such as the target vessel and the degree of proximal stenosis, that we were not compromising the patency of the graft when used in a sequential fashion. Here's the patency of the segment above the sequence, and then the segment below the sequence. And so again, done properly, thinking about the lie, the size of the vessels, you can have excellent results sequencing arterial grafts, and particularly mammary grafts. Now, sequencing is one way to use your grafts efficiently, and it does allow you to do more arterial coverage. But I would argue that kind of the best way is really to start thinking about composite grafting, where we use the arterial inflow, let's just say, of another graft, such as an in situ ITA, to use as the inflow for other grafts. This allows, again, we don't have to have as much graft, transverse long distances to get to where we go. But also it allows you in situations where you don't have to take as much mammary on the right side. This can be important in preventing wound complications, long term. Let's just say you just need to get to a mammary in one circumflex. You may just get 8 to 10 centimeters to the right mammary and still have most of your right side of your sternum not devascularized. So again, offers some opportunities. This composite graft anastomosis is often referred to as a T or a Y anastomosis. I like to put this inside the pericardium, and it'll make sense in a second, how I do that. Some people put it outside, but I think that can make it a little bit more difficult to get your lengths of your grafts right. And then also, when do you construct this? I actually construct this anastomosis when I have completed all my sequential anastomoses, just to make sure that my lie on the heart is perfect. And again, I'll show you that in a minute. As you can imagine, we also looked at this. Are we compromising, particularly our ITA to the LAD when we do a composite graft? And so we looked at the patency above the composite, below the composite, and then also, what is the patency of the actual composite graft itself? And so what we found, as you can suspect, is excellent patency above and below the segment, but disappointingly, our Y graft patency wasn't as great. And I'm going to show you that here. When we use our gold standard as the in situ leader to the LAD, and then we look at the segment above and below our composite, we see that we're not compromising the ITA graft at all with this configuration, and the patency of the composite is still excellent and very good, but not quite as good as the in situ leader to the LAD. That may have due to other factors, but I think the important takeaway is that number one, we're not compromising the ITA to the LAD, and that over the long run, the patency of this graft is still better than any vein graft, because early on it's better, and over the long run, it's better because we don't develop atherosclerosis. Now, another important, consideration that people take is, well, when you do these composite grafts, is there actually enough blood flow? And I think this is another excellent study done by my, friend, Dr. Glenier, who actually used FFR and looked at composite grafts to see that if you put the lima to the LAD and then a Y graft to the circumflex, was there enough flow in that native stem part of the left of the LAD, kind of the new left main? And the answer to that is yes. But an important takeaway here is that most of us who do this will not do the entire heart circulation on just the inflow. And what I mean by that is we may revascularize the whole left coronary circulation, but we won't put the right coronary into this. We believe that the right coronary has to have an additional inflow, because then you could have situations where you just don't have enough flow by that internal mammary. But you can clearly, as Davis has demonstrated in these very nice studies, really completely revascularize the left side of the heart on the inflow of one internal mammary arteries. Okay, so let's get back to our patient. This is, I think, the fun part. You guys have endured the last 40 minutes with me, going through how I think about coronary artery bypass grafts and how we should use them. And so now I'd like to show you how I use them. Again, we're going to get back to the patient who you saw the angiogram, the young man with extensive coronary artery disease that I think we would all agree needs many grafts. probably not the best candidate for vein grafts because he's young and he's hyperlipidemic and he smokes, and we know that vein grafts do bad in those situations and that arterial grafts, do better. And so our planned approach in him, and I like to do my surgery on pump unless there's an indication to do it off pump. I think it allows me to get excellent, outcomes without increasing risk. Again, I'm going to do it on pump with the heart arrested. We're going to do all arterial grafting. We're going to use both internal mammary arteries. We're going to use the radial artery, and we're also going to use the gastroepiploic. Again, it's something I enjoy doing. So here's the video. Now, the first thing is we're going to harvest the internal mammaries. And I believe it's extremely important to do this in a skeletonized manner. There are a lot of people who do this with the harmonic scalpel. I tell people, I'm kind of a cheap Cleveland surgeon. I just use my cautery and I open the fascia, and then I identify my mammary arteries, and then I do clip, clip, cut, the branches. And by clipping and cutting and not boving the branches, I'm not interfering with the collateral flow to the sternum. And you saw a little bit earlier, the radial artery that was previously harvested by my assistant while I was taking the mammary arteries down, and they do that endoscopically now very nicely. You can see this guy's a little bit overweight, and we are taking the gastroepiploic, so there is a good amount of fat or adipose tissue, but you can see very nicely the little short gastrics, the branches to the stomach. And what you do is you just kind of deliver the stomach, through the upper abdomen into your wound, and then again, it's just clip, clip, cut, all the way. And you'll see you can get a very nice length. And here you can see the length of this gastroepiploic. You can see I did take it with a pedicle. I probably need to visit my Asian colleagues and see how they do it without a pedicle, but I find it very easy to do this way. But you can see we can reach the LAD. We've obviously gone on pump. We've arrested the heart, and this is the lateral wall. And we're looking at the circumflex branches. I don't know if you can remember from the calf, he had a pretty nice, high circumflex, and then also a relatively nice kind of more lateral or posterior lateral circumflex. And I do spend a little bit of time just looking at my targets and thinking about where's the best place to graft these vessels and how I want to use my conduit. Here I'm bringing in the right internal mammary. We've taken the entire length of the right mammary, and we're going to use it as a composite graft, but we're going to use it to sequence both of these circumflex arteries. I'm going to do a parallel anastomosis of the mammary, to that high circumflex, because the high circumflex is quite a large vessel. Now, we do have a very nice mammary here that is a large vessel, so you could consider doing it in a diamond anastomosis. I personally just feel very confident about my ability when doing a parallel anastomosis and how I can do this in a sequential fashion and feel very confident. And now we're going to do an end-to-side anastomosis to that posterior lateral circumflex, and it's going to kind of be done in a T fashion. I know a lot of people like doing their mammary anastomoses with 8-0 suture. I like to use 7-0. I don't find 8-0 necessary, but when we do the gastroepiploic, we will use an 8-0. But this is just like you would do any anastomosis. And then again, as you can imagine, when you drop this heart back in the chest, it has the possibility of that graft twisting on itself. So I spend a little bit of time tacking the graft in place. And I have to admit, I learned that the hard way with a patient who developed ischemia post-op, and we took him to the cath lab and we found that graft was twisted. And so I always just spend a little bit of time looking at my layout and tacking the graft down so that I know when I'm done it's not going to twist. Here we're looking at the anterior wall. We've used the left internal mammary artery as a sequential graft with a parallel anastomosis to that large diagonal, and then an end-to-side anastomosis to the LAD. And I've actually taken the bulldog clamp off, and so you can see the mammary is nice and full and it lies very nicely. And again, I tack the graft down. I did use a radial artery to graft another higher diagonal that I didn't think I could sequence well. But now I'm going to show you how I do that composite anastomosis. And this is what I mean by doing it inside the pericardium, because now I'm still on the pump, the heart's arrested, but I'm going to fill the heart and I'm going to run antegrade to get some fullness to my graft and figure out where I want this graft to lie so I don't have to worry about it kinking. I then tack the mammary artery down to the epicardium of the heart and then just sew a kind of a T or a Y-shaped anastomosis, and it lies very nicely. And here's the gastroepiploic. It's been brought through kind of a small cruciate incision in the lower part of the pericardium. And I'm going to bring this gastroepiploic through an anastomosis to the posterior descending artery. And here you can see it's a nice artery. It's kind of similar to what you might see with a small mammary, but clearly very usable. You can see the guy has had a little bit of infarction in his inferior wall that we didn't pick up, preoperatively with his preoperative studies, but you can see a little bit of scar tissue there. And again, we're just going to do a nice anastomosis using an 8-O-proline of the gastroepiploic to the posterior descending artery. I like to clean the hood off of the anastomosis, whether it's a mammary or a radial or a gastroepiploic, just to make sure I haven't caught any bands. And here you can see we've come off the heart-lung machine, we've decannulated, and just kind of lifted the heart a little bit to drive my anesthesiologist crazy, but just to show you here how nicely these grafts lie. There's no kinking, they're not too long, and it all sits very nicely inside the pericardium. And again, it's allowed us to do an all-arterial graft operation, in this gentleman who's young and who are hoping to get a very good long-term result. You can see just underneath my forceps is where the radial artery has been anastomosed, to the LAD. Well, thank you very much. I really am very honored by the opportunity to give you grand rounds. Having the opportunity to speak in one of the meccas of heart and vascular surgery in the world, Houston, is an incredible privilege for me, and I want to thank Dr. MacGillivray and all of his colleagues for such the kind invitation, and I'd also be very happy to answer any questions that you may have. Thanks again.
Joe, that was a great talk. It was very informative, and really the video of the operation was very elegant. We have a bunch of questions, and I'll try to put them together in categories. We all know that multiple arterial grafting is a common topic at meetings and in papers, but it really has been uncommonly adopted by surgeons. And at the last STS meeting, it looks like it's about 6 or 8% in men and even less than that in women. So, Joe, why, in your opinion, why is that, and what can we do to increase its adoption among surgeons?
Tom, so I think there's a few reasons. First of all, I think all of us would agree that when it comes to aortic surgery or maybe mitral valve surgery or aortic root surgery, that it's a specialty in itself amongst cardiac surgery. And when we send somebody, who has an aortic root aneurysm and we want a David procedure, we're going to send them to someone like you, who's a real expert. But unfortunately, that hasn't happened with coronary surgery. And even in my old institution, it wasn't uncommon for coronary surgery not to be taken that seriously, and anyone can do it. And I would argue that, yeah, anyone can do it. But just like anyone can do a Bentall, not everybody can do a David procedure. And I personally believe that coronary surgery should be treated with the same respect, and that it should be a subspecialty of cardiac surgery. It should be done with people who enjoy it and are interested in it and are willing to do these type of operations. But that hasn't happened. I don't know how to change that. The way I hope about it is by having the opportunity to give talks to people to show the benefit, and that it's not like something Michael Jordan needs to do. People, I believe, who dedicate themselves to this field can master this very well. But I think they need to be supported. I would love to see cardiac surgery, divisions and groups say, okay, we're going to have 1 or 2 designated coronary surgeons, and just like we look at our aortic surgeons for their quality, we're going to have quality metrics the same way. Are they using 2 mammaries? Are they using radials? What kind of procedures they're doing? But unfortunately, that hasn't happened, and I think that's why coronary surgery hasn't progressed to the same degree as other areas of cardiac surgery have. Also, I think, there is the competition of percutaneous intervention. I like to look at my interventionalists as, we're colleagues. We solve problems together. This patient I showed you is clearly not a candidate for PCI because of the extensiveness and diffuseness of disease. but is an excellent patient for coronary surgical revascularization. So we have to look at them as complementary procedures. But if all we're doing is an IMA and a bunch of veins, it's hard to make that argument that that's better than PCI today.
It's interesting that you say that, Joe, because you bring up the idea of a Bentall versus a David, and my good friend and colleague Mahesh Ramchandani and I talk about this all the time. Coronary artery surgery is, I think, one of the more challenging operations to do well. I mean, we take it for granted. It's been an operation that's been around and commonly performed for decades, but to do it really well and as elegantly as you showed in your video, it's technically a very demanding operation. So we've had several questions from around the world by, I presume, trainees. What advice, Joe, you as a master coronary surgeon, what advice would you give a trainee or a young cardiac surgeon? How can they develop as a coronary surgeon? Do you start off doing an operation like you just showed us? What's the formula for success?
Well, I think when I think about how I teach people how to do coronary surgery, how I teach my residents, it's incremental. And I would say, as I've taught myself over the years, it's incremental as well. Now, I was very fortunate to be trained by just some world-class coronary surgeons, Bruce Lytle and Fred Loop, and I'm always will be indebted to them, for the knowledge they impart on me during my training. But I try to do the same thing. And so what I would say is that I think we're all at the end of our training very comfortable with doing, let's just say, a mammary to the LAD. And you might want to set for yourself an incremental, like when is a good situation to sequence a mammary to diagonal and LAD? And I would say the ideal situation is when you have a diagonal that's parallel, to the LAD, so you can do a nice parallel anastomosis, and so that's a nice way to learn sequential anastomoses. Don't start off right away with the more complex diamond anastomosis where you can get yourself in trouble. Use the parallel anastomosis. And then I think when you start thinking about a second arterial graft, I would say start with the radial. Mario Gardino has just done some great work demonstrating that using the radial in the right situation gives you equivalent results to two mammaries. And the nice thing about the radial, it's a little bit an easier conduit to use as a free graft. And so it's a nice thing to learn how to do sequential arterial grafting on the side of the heart, or just the second arterial graft on the side of the heart. And then you can start off putting it on the aorta, and then you can put it on a very nice mammary to teach yourself composite grafting. And then the second thing you might want to do is that, okay, now I'm going to try this operation with two mammaries, because that does increase the complexity a little bit. So I think, be patient with yourself and put yourself in situations where you'll succeed. Never put yourself in a situation where you might fail, right? Because the patient's going to suffer. But by, I think, incrementally improving your talent and your ability over time in situations that are easy for you, but I always tell my residents, one of my favorite quotes, and I hope I don't get it wrong, with time, the impossible becomes possible, the possible becomes probable, and the probable becomes reality. Yeah. And I think if we approach all surgical learning in that way, we can master a lot during our careers.
Joe, I guess time for one last question. As you know, last year the ischemia trial was published. We have a big audience, not just of cardiac surgeons, not just cardiologists, but also primary care providers from all over the world that are tuning in. So what's your perspective of how we should interpret the ischemia trial with regard to strategies for revascularization?
So that's obviously a very tough question. And, first of all, I want to say, having been part of some of these very large multi-center prospective studies that takes 10 to 15 years to do, that, they're an amazing achievement. And I want to say that the ischemia study is an amazing achievement. But looking at it from a critical eye, we know the percentage of patients that had surgery was very small. The percentage of patients that had extensive multivessel disease was quite small. And then to interpret that and say that anybody with multi-vessel coronary disease doesn't benefit from revascularization, and we probably should try medical therapy first. I think that's a stretch. And I know that people, disagree with me and put a lot of weight on that study. But I think when we think about any study, there's always bias. And when we look at a randomized study such as ischemia, there's bias about who was entered into that study. And I would argue that the patient, and I know they didn't have angiograms, but they did have CTs to detect left main. But I bet there was some bias in people who were enrolled. And then when we actually get into the actual numbers, and I know, Tom, you wrote a beautiful editorial on this in one of our journals, that again, the number of patients having bypass surgery was small, and the number of patients who actually had anatomy that would have made them qualify for bypass surgery was even smaller. So how can we draw much in the way of conclusions about whether this is applicable to your actual patient being referred to coronary surgery? I think that's a reach.
Well, Joe, I want to thank you very much for really a beautiful talk and for being a leader in coronary surgery. You do us a great honor by spending an hour with us and educating us. So I'd like to thank you very much and thank everybody else for tuning in and watching. Have a great day.
Thank you, Tom.